Good morning, everyone. As you can see, today we will be discussing about the radiopaque lesions of the jaw. For an introduction, when do we call an object radiopaque? So as you can see, a tissue or an object is radiopaque when it hinders the unrestricted passage of X-rays and therefore it appears white. When there is a hindrance in the passage of X-rays, resulting in that object or tissue appearing white. So we need to do a systematic approach for analyzing this kind of an image, a step-by-step analysis, that is localizing the abnormality, assessing the periphery and the shape, analyzing the internal structure. Before we move on into the radio-opaque lesions as such, first we need to know the classification of a bony lesion. So the bony lesions, they are mainly classified as radiolucent lesions, mixed radiolucency, that is, it will contain some amount of radiolucency and some amount of radiopacity, and radio-opaque lesions. Now these radio-opaque lesions are again divided into various types. First is the anatomic radio-opacities. Then is the radio opacity contacting the tooth, radio opacity not contacting the tooth. These radio opacities not contacting the tooth are again divided as solitary, multiple, and generalized opacification. Now the anatomic radio opacities, they are again classified as three, that is common to both maxilla and mandible, only seen in the maxilla, only in the mandible. Common to both maxilla and mandible are the teeth, lamina dura, cortical plates, alveolar process. Seen particularly in the maxilla are the anterior nasal spine, the walls, floor of the sinus and of the nasal cavity, zygomatic process, maxillary tuberosity. In the mandible, the external oblique ridge appears radio-opaque, internal oblique ridge appears radio-opaque, mental ridge, and the genial tubercles. In contacting the tooth, the periapical lesions included are condensing osteitis or sclerosing osteitis, mature focal cemento-osseous dysplasia, hypercementosis, periapical idiopathic osteosclerosis, cementoblastoma, retained roots, and cementifying fibroma. Now, the not contacting the tooth kind of radio opacities are divided into three, mainly solitary, multiple and separate, and generalized opacification. In the solitary, the tori, exostosis, osteoma, impacted teeth, sclerosis, osteitis, osteomyelitis, and osteoma. All these are solitary, not contacting the tooth kind of radio opacities. Multiple and separate, not contacting the tooth kind of radio opacities are socket sclerosis, focal cemento-osseous dysplasia, cleidocranial dysplasia, and hypercementosis. The generalized opacification include Paget's disease and osteopetrosis. False radio opacities include mucosal cyst of maxillary sinus, silolith, antrolith, and rhinolith. Periapical radio opacities, we'll be seeing a few of them. The first one is condensing or sclerosing osteitis, sclerosis of bone, induced by inflammation or infection of the teeth, mostly due to pulpoperiapical lesion. There will be proliferation of the bone tissue. Most important clinical feature is there will be non-vital pulps in the involved teeth. Usually, there is a 3:2 gender ratio, that is female is to male. Management is more commonly extraction of the infected teeth or even root canal wherever it is possible. Next kind of radio opacity is the mature periapical cemento-osseous dysplasia. The clinical features usually seen in the age above 30 years. Gender, females, it is more common. Site is mandible anterior region. Another clinical feature important over here is the tooth will be whitened. Differential diagnoses include hypercementosis, periapical idiopathic osteosclerosis, condensing osteitis. The third radiopacity contacting the tooth is hypercementosis. It is usually asymptomatic. The most common site is premolar affected more than molars. Here again, the tooth will be vital. Radiographically, club-shaped tooth, root, and in the differential diagnosis, we can include condensing osteitis, developmental anomalies, fused root, and dilacerations. Cementoblastoma is again another radiopaque lesion, mainly affecting the young adults in the mandibular first molars. Here also the tooth will be vital. It is attached to the tooth root. Radiographically, you will see initially a radiolucent halo surrounding the dense opaque mask. It extends higher into the root as the lesion grows. For differential diagnosis, mature periapical cemento-osseous dysplasia. The next lesion is retained roots. They also appear radio-opaque. As you can see in the image, there is a radio-opaque root remnant. Radiographically, it will be seen as a homogeneous root tip shadow. Differential diagnosis included unerupted tooth or even mature odontoma. The next is solitary radiopacities. The first one is tori or exostosis. It is a peripheral, benign, slow-growing, bony protuberance of the jaw, mainly affecting adults. There is no particular gender predilection. Palatine tori is an example affecting the hard palate. Mandibular tori is another one that is seen bilaterally, mainly in the premolar region. Differential diagnosis, we should be able to differentiate it from mature mature cemento-ossifying fibroma. Mature odontoma is another type of radiopacity. It's a solitary radiopacity. Slight predilection in male. Slight gender predilection in male. The most common site is pericoronal to impacted teeth. Radiographically, homogeneous, dense radiopacity is seen as a well-defined, smooth, radiolucent rim is seen surrounding the lesion, and a well-localized opacity with a frayed margins and a sunburst appearance. We need to differentiate this from periapical cemento-osseous dysplasia or florid cemento-osseous dysplasia. And cementifying fibroma. Cementifying fibroma usually has a centrifugal growth. Next is osteoma. It is a rare benign tumor of bone. The main clinical features include it has a male predominance, and usually in the skull region, it is seen more commonly in the mandible. Radiographically, it is seen as a homogeneous, rounded radiopacity, superficial or within the confines of bone. Density that is very similar to that of the surrounding bone. We need to differentiate this from benign osteoblastoma. Treatment is surgical excision. Gary's osteomyelitis, proliferative periosteitis is another name, usually seen in children, and very rarely is it seen above the age of 30 years. A more gender predominance is seen in males. The site most frequently is the inferior quarter of the mandibular first molar. Facial asymmetry is very common. And simultaneously, it can be seen in all the four quadrants. Radiographically, it is seen as a laminated appearance. There will be a convex, bony shadow from the cortex. Differential diagnosis, we need to differentiate it from Edwin's sarcoma, osteogenic sarcoma. Next is multiple radiopacities, that is ossifying subperiosteal hematoma. Hematomas develop subperiosteally, usually after trauma to the bone. Radiographically, it will be seen as a dense, radio-opaque, convex expansion of the periphery of the bone. Mottled appearance is another radiographic appearance. We need to differentiate this from Gary's osteomyelitis and tori, exostosis, or peripheral osteoma. Cleidocranial dysplasia, again, radiographically, you will see that there is a small, underdeveloped maxilla, usually micrognatic. Paranasal sinuses also will be affected. Mandible is usually normal in size. There will be prolonged retention of deciduous teeth. delayed eruption, supernumerary teeth will be there with dentigerous cyst formation. Unerupted teeth are the most common in the anterior maxilla. Differential diagnosis is Gardner's syndrome. In the generalized radiopacities, first one is diffuse sclerosing osteomyelitis, rare lesion with features similar to that of fibrous dysplasia. So the most common site is mandible along with the molar, angle and lower ramus junction. There will be recurrent pain, swelling of the inferior aspect of cheek and trus. There can be trismus. We need to differentiate this from fibrous dysplasia and Paget's disease. False radiopacities is another important part of radiopaque lesions. Mucosal cysts of maxillary sinus. They occur in approximately 2% of the population. Radiographically, it will be seen as a dome-shaped mass with base from the floor of the sinus, overlapping the apices of maxillary and second molars. Differential diagnosis, you need to differentiate it from condensing osteitis, idiopathic osteosclerosis, and periapical cemento-osseous dysplasia. The last one is anthrolith or rhinolith. These are calcified masses in the maxillary sinus or in the nasal cavity. Radiographically, they'll be seen as dense, irregular, well-defined mass on the antral floor. You need to differentiate this from antral retention cyst, root fragment in the antrum, and root fragment and periapical condensing osteitis.